if it's a first-time patient with an EKG, they'll say, am I going to feel an electrical shock? You always get that question. And I say, absolutely not. There's no charge going through you.
Today's lesson is brought to you by the letters ECG, which basically stands for electrocardiogram. An electrocardiogram is an electrical tracing of the heart's activity, past and present. So the doctor can tell if you've had a heart attack 10 years ago opposed to just a few minutes ago. What type of individuals actually get this test? Patients with past history of cardiac problems or heart problems. If you need a physical exam for insurance purposes.
Some people come in with pulled chest muscles after moving equipment or moving, furniture, and they're saying, oh my gosh, my chest is just killing me. Well, with an EKG, you can automatically narrow out, okay, is it heart related? Is it muscular? Is it pleurisy? I mean, that can be pretty painful also. With a nice EKG, which is quick and portable, and the doctors can look at it immediately before you unhook them. You can have the doctor take a look at it and say, oh yeah, okay, this is okay, unhook them, and now I know where to go.
When they do an ECG, yes, generally someone is complaining of chest pain. Yes, there is probably a blockage somewhere, but the ECG is monitoring the rhythm just in itself to see whether or not, due to maybe a myocardial infarction, that the rhythm is off. Now, MA does not diagnose, so we're not going to diagnose that ECG. We're going to perform it for the physician.
You need to know placement, okay? You need to know why you're doing it, because your patients are going to ask you, why are you doing this? Or am I going to feel an electrical shock? That's a big question. Be prepared to answer those questions simply, because you're not an EKG expert. You don't read them, but you will perform them.
In the latter days, it was called EKG, but there's no K in electrocardiogram. Switching it to the ECG, because there is a C in electrocardiogram. It is more prominently known now as an ECG, but those of us from the old days still call it a EKG.
Now, the most difficult aspect of actually performing the EKG is lead placement. Even I had problems with this. But if you come to class every day and practice, you'll be a pro. First of all, we have to feel for the intercostal spaces, which are the spaces located between each rib.
So the intercostal spaces are between the ribs, and they are wider in some people than others. So it has to be on an intercostal space. An intercostal space, you would be able to take your finger and kind of put in that area. And when you put your finger on it, you can tell that your finger will dip in. And when it dips into the skin, that's an intercostal space.
You're going to have a lot of practice with this. Your clavicle is the beginning of your intercostal spaces. So the area located just beneath your clavicle or your collarbone, that's the intercostal space number 1. So the first V1 lead is actually going to go on the 4th intercostal space, right margin of the sternum. So what does that mean? It means I'm going to place my electrode in the 4th space between the rib, just right of the sternum. The sternum is your breastplate, which protects your heart, because your heart is located in the center of your chest.
So it's a matter of counting down from the clavicular area to find those spaces. And sometimes when you're in an urgent case, that's a fast thing to do. So it's the knowledge of doing them over and over that gets you to where the spaces need to be.
Lead V2, or your second electrode, will be placed directly across from lead V1. Same 4th intercostal space, but it's going to be placed on the left margin of the sternum. This is where it becomes complicated. There's a V3, a V4, a V5, and a 6. However, you need to place V4 strategically before you place V3. Yeah, I know. I'm going to repeat myself. So V4 is actually placed on the body before V3. V4 is placed in the 5th intercostal space, which is located just underneath the breast. Okay? but you want it to go mid-clavicular line. You want it to line up just about here. 5th intercostal space, but matched up in the center of the clavicle bone or your collarbone. Now, we can go ahead and place lead V3, which is midway between V2 and V4. Now, as you can see, the bulk of the electrodes are going to be placed on the left side of the chest because although your heart is in the center of your chest, the apex actually beats more prominently on the left side, so we can get a better tracing from the left side of the chest cavity. Now we're going to place lead 5. Lead 5 is placed horizontally across from lead V4, but at the beginning of your armpit or axillary line. Okay, the beginning crease of your armpit, but horizontal to lead V4. Now, can you see how that is coming along? The tracing of the heart? Awesome. Next, we're going to place the last chest lead, which is V6. It's going to be lined up with V4, V5, and V6. And V6 is going to be mid-axillary line, or the center of your armpit, you know, where you place your deodorant on, okay? Now, we have our chest placements, and always remember your chest leads are also referred to as your precordial leads. These are your chest leads. So there's 6 of them, and we're done. Now we have 4 electrodes left, and they basically go on your extremities, your arms and your legs. For your legs, you may want to place it on the fleshy part of your calf, and for your arms, it can usually be placed on your wrist or any place where there isn't any tremors.
It is about the positioning of the electrode and the lead, getting it in the right position, not necessarily on a bone. You know, you don't want it on a bone, you're going to get bone artifact.
I just ask the patient, this is going to take just a few minutes, if you could please lie still and just breathe normal, because you can get muscle interference, which is artifact if they're moving. So I just ask the patient to lie still, and it doesn't take very long, maybe 30 seconds to run it.
Making sure the patient is at ease when this is going on, because they're getting an ECG, they're nervous. You know, and nervous can inhibit the reading of the ECG.
You cannot say, okay, I know where they look like they go. You have to know, feel the ribs, feel the chest, know exactly where the mid-axillary line is, because on a kid it's going to be different than an adult.
You always make sure they have a drape sheet, maybe an extra drape sheet to cover up with. And when you're moving around the chest area, you want to make sure that you're rolling up the drape sheet or the cape, whatever your physician's office has, around the breast tissue. Don't reveal the breast tissue. There's no reason for that. Just kind of moving it around to the areas, because the 4th and 5th intercostal actually kind of just cup the breast area. Now, if you have an enlargement breast, an over-enlarged person, sometimes those would be right on the breast area. But there is absolutely a way to cover and keep your patient feeling like they're covered through the whole procedure.
You have to make sure the flesh is clean, free of any excess oil, baby powder, jewelry, and some patients may have a lot of hair, but don't bring out the old razor until you get consent. If the patient has excessive hair on the chest, you may want to just shave off little squares where the electrode can actually go.
V1 goes on the fourth intercostal space to the right of the sternum. V2 goes on the fourth intercostal space on the left of the sternum, adjacent to V1. V4 goes on the fifth intercostal space, mid-clavicular line, right below the nipple. V6 is mid-axillary. V3 goes in between V2 and V4. V5 goes in between V4 and V6. Next is the limb leads. Left arm, the right arm, left leg, and the right leg. Each lead is numbered. The lead that says V1 goes first, V2, V3. If the leads get tangled, be careful to check the leads to make sure they're going in the right spot. If you accidentally mix a lead up, let's say you put V1 on V3, once you print it out, it will let you know that you need to switch the leads around. While we run the test, the patient needs to lay still and no talking.
I really stress with the students, be very knowledgeable about why you're doing it. You know, we're monitoring the electrical activity of the heart. Your patients will ask you that. Know where those leads are, know how many leads you're running, and just be ready to explain to the patient. I'm really a big patient advocate because that's why we're there. And, you know, if we can't take care of that patient, they're gonna go elsewhere. Explain to the patient what you're doing, whether it's an EKG or anything.
You should be able to have an ECG placed within 3 to 5 minutes. No exception.